Dr. Gorang, please. Prashant is already there. Please moderate the session. And I invite Dr. Shabbir to present his deliberation. Dr. Shabbir, please.
Good morning, everyone. I thank the West Zone Council and I also thank Dr. Kamlesh Maurya for giving me this opportunity to present uh, the shock pulse lithotripsy machine advantages in this forum. Respected seniors and dear colleagues, the topic I'm covering is shock pulse lithotripsy. Shock pulse lithotripsy is nothing but uh, dual energy in a single probe along with the aspiration, along with the suction device. So that is basically a combination of dual energy as well as suction to produce the efficient and the faster clearance of the stones. So we will try to understand the machine as well as the advantages and the disadvantages of this machine in a short lecture. Greetings from Jabalpur to Bilaspur and West Zone. Dear friends, as we have since the inception of the PCNL, the urology community is in search of removing the fragments very fast and to fragment the stone at easiest and to remove it as early as possible. So initially with the advent of pneumolithotripsy, there was a larger fragmentation and there was the larger amplasties were used and we used to remove the stone faster. But as we have reduced the size of our bores and then removing the stones from that smaller channels or smaller amplas has become difficult. Then came the era of maybe the lasers have came in and they have ruled this intracorporeal lithotripsy for around now 15 years. But again, see, always it is like that, dil mange more. So we are not satisfied. We want to have something better still. And there are some circumstances which we see at times the laser and even a pneumo may not work very well for us. So we are in search of a device which will be having a safe and which is safe and easy to use and have an efficient stone fragmentation and a faster removal. Sorry. So I think this again, this device with a dual energy and a suction is a way to go. I'm sorry because see, these videos are not working. I've tried hard because they were made in Windows 2007. They're not functioning. We have seen the machine. I think this was a machine video. This machine is a very simple machine which the Olympus company, because we have to name the company because only one company is available at present with this dual energy in India. And there is one more machine which is available with the Nadia, that's a Triology, which is mainly available in a European market, not available commercially with us in India. So that is a very easy and plug and play machine with a and it is portable also, which has got a one transducer which we were seeing yesterday with a probe, and probe are of different sizes for the different to adjust into the different nephroscopes. And there is a dual control. It is a hand-head control and all. There is a foot control also. One control works at a time. If you are tired, and by pressing the hand control, you can use a foot control. For a larger stones, I usually use foot control because otherwise, no, this thumb gets fatigued. Now, coming to the principle of this machine, this is producing ultrasonic, continuous ultrasonic waves at very high frequency of 20,000 hertz. And along with that, it is producing intermittent ballistic component is there, a pneumatic component is there, which creates a hard hit on a stone and which creates so that the fragmentation is becomes faster. And it is a proprietary technology which they have not disclosed to the others. So again, important thing is what they have done is along with the fragmentation, they have used the probe which they have made has got a very large channel that is up to around 3.2 millimeter. So that can suck the fragments up to around 8 to 9 millimeters. A larger fragments can be sucked very easily with this probe. That is the advantage. Even the triology has got a still slightly bigger lumen size compared to the shock pulse. Then one important point I want to highlight regarding managing this device is very important thing is managing a suction. In many of our colleagues who have used this device are not satisfied, maybe because of the inappropriate use of suction. There is a probe, there is a suction control knob at the back side of this transducer. So you have to adjust the knob almost in the middle so that the irrigation what is going is not sucked completely. If the water is not there, then the vision is lost. The mucosa falls on the tip and you are lost. And then the device is not used appropriately. So managing suction is a very important part of using this device. These are the different probes available. For the standard PCNL, there is 3.76 millimeter probe, there is 3.4 millimeter. For the mini perk, it is 1.83. And there are two probes available which are less commonly utilized are for the URS 1.5 and even 0.97 millimeter probe. I am practically using these three above for the PCNLs and not for URS. The company has done little bit change in the probes recently. They have come up with the DLC probe which we have used yesterday. That is 3.4 mm. We have used DLC. That is a black color probe. The advantage being there is an increase in the durability because they are reusable, but to the certain extent. So increase in the durability. Increase. If you have seen the yesterday my movement, just if you move the probe little bit, there is a movement of the camera because it is snugly fitting. So these DLC probe have got a better lubrication so that once we move the probe, our camera does not move. That lens does not move. There is a reduced flaking, means the lateral damage has been decreased with the improvement in this DLC probes. And the visibility is there once there is some blood. So the light reflection is less. The initial probe were of the stainless steel color. They have got a black color so that they can be seen better at the times of bleeding. This is the advantage of these DLC probes. I'll just describe the case. Sorry for video not running. There are few situations. Number one, this was the case when even I have tried one. I took one case like we have yesterday's. I tried for a smaller stone, but having a mug and the flakes and like a matrix stone. If we use laser, it gets fuzzy, but it does not break. If you use pneumo, it goes inside, but it makes a hole, but it will not fragment. So these are the stones where this machine works wonders. They suck the stone like anything. Even the case which I got yesterday, it was a similar type, having a lot of matrix sort of component. So that is the cases where it works very well. Number two, there are cases when suppose there is a large stone in a pelvis with a secondary maybe 500 stones, small size stones in the lower calyx. And we go inside, we fragment a large stone, then we are troubled by removing those small stones, very minuscule stones, maybe in 500, thousands, they are lying down in a lower calyx. Either you puncture and then flush it and remove it, or else what this machine can do for you is, it can suck the stones with a faster rate so that the repetitive movement of taking the scope out again, and which can cause even the ache at times in the neck and the shoulder, that is avoided. And the time also reduced. The case 3 is a case like this is have got an advantage. See, even now we are having a smaller stones, but at times we are faced with the stones which I was operating yesterday. So in such stones, even with the single puncture, you may able to complete the case. Even for that matter, I selected the upper calyx, reason being once you are from the top, you can go up to all the places in the kidney. And what it does for us, the stone migration is prevented at times, and even it sucks the stone from the other calyces, so they come in front of you and you can then remove it with this. At times what happens, suppose a small part of the stone is seen but rest of thing is going inside. If you do pneumo, whole of it will go in one particular calyx. So in that case, we put the you put the probe in the stone and make a drill and then pull that stone in front of you. That is the added advantage with this stone, with this probes and machine. One thing is I always advocating, and what I see, once we are removing a large stone, we tend to leave a small fragments or particles for the natural currents because we are tired and it is very difficult to remove a small stones. So we may do a brewing, but what this probe can do for you is a sweeping. It cleans all those very small fragments very efficiently. For that matter, this thing I utilize even in day-to-day practice. When it's a stone, when I have broken with the pneumo or a laser and there are a small fragment, then I use this probe to suck out those fragments, and it gives the added advantage and it saves the time. So that is the, see, this machine is not a one thing which we can recommend to keep for the stone disease, but it is a very good supplementation in your stone armamentarium over your pneumo and the laser for the particular or selected cases. Coming to the drawbacks, one thing is the initial cost that the company has kept is the drawback for the utilizing this machine, and second thing is the recurrent cost of the probes. But what I have felt over around 3-4 years, that probes, if used judiciously, they have got a prolonged life, and you may use the one probe for around 20-30 cases. One thing I want to highlight here is this probe usually does not work when the densities are very high to the tune of around 1300 to 1600. In that case, the probe get means overused and get spoiled very early. So in that case, I use pneumo first and then use this probe to remove the stones. And the, so that's how we can prolong the life of these probes and have an advantage. And just trying to reviewing the literature of late, after around after 2018, there are a lot of literature has come up in removing the stone with the dual energy with suction. So now this device and these types of machines, there are a lot of in pipeline. Some of them are not been commercially available, but they were in the they have been researched, and few are now coming up with the finally in this market. So these are many studies which are showing the effectivity of this dual energy lithotripsy system over pneumatic. So now this will be the way to go in removing the stones. This is one paper from the initial clinical evaluation of shock pulse stone eliminator in percutaneous lithotomy. The conclusion was clear, and the shock pulse is equally effective and in some circumstances more effective than the 3 commercially available devices. One thing, finish. Yes, yes. Sir, sir, last thing, there's a paper from Nadia Group Subnis, sir, has already, they have studied lithotripsy device, shock pulse along with the triology, and the conclusion in their paper is also that it is less time consuming, more effective. That is the conclusion from the Subnis, sir, and et al. Thank you.
Hello,
Okay.
Kamlesh. We are connected to the OT. Anybody there? I request Dr. Sabni sir to give memento to Dr. Shabir Hussain. Just let us inquire from the OT. वहाँ से ऑडियो है क्या? हेलो. हेलो डॉक्टर कमलेश. नहीं ऑडियो नहीं है. पेन ड्राइव हो गया. हाँ पेन ड्राइव हो गया है. तो बोलना ना.
Can we have Dr. Lalit Shah and Arun, Dr. Arun, to chair the session? You are going to be moderator, no? Okay, okay, okay.
Yeah.
हेलो डॉक्टर चंद्रमोहन.
Well, once I'm live, let me know. है ना?
हेलो. हेलो.
You're showing the. अच्छा.
हाँ, आदित्य.
Hello.
Sure, sure.
Hello, can you hear me, sir?
Yeah. Can you
Good
be?
morning, sir.
Good morning.
So after a hectic night, we're all ready.
Yeah, we are. We
First
are.
case.
मेरे को वो
Okay.
देना.
Sir, first
Tell
case
him.
is the ECI RIS. Dr. Chandramohan is going to do the RIS part and Dr. Adit will be doing the supine PCNL part. So I'm just handing over the mic to Dr. Chandramohan. Just start and then Adit will explain you everything.
सर वो पोजीशन एक्सप्लेन दिखा दिया वीडियो. पोजीशन वाला वीडियो प्ले करा दिया.
Hello, good morning, sir.
Hello.
Good morning. We can hear you.
This is a case where there is a large stone in the upper pole region, one stone in the middle pole region, one stone in the lower pole region. You see here, right side, very complex case where significant load below and above was there. It was operated by Kamlesh sir a few weeks back and he completely cleared. No need for relook. Now we are focusing on the left. One large stone in the pelvis or
थोड़ा
upper,
पीछे.
we don't know.
थोड़ा पीछे करो.
One stone in the middle, one stone in the lower. Now Dr. Aditya Shukla will demonstrate supracostal puncture because this is a large stone burden for RIRS naturally, and these two are small stone burden. If we go here, he may not come to these two places. So I will go first. I will take this stone, or I will finish with TFL very fast, these two, with direct popcorn effect,
and after that I will inject contrast, my job is done. He will do this so that patient need not have 3 punctures or awkward movement into these cases. This is the ideal case for RIRS. If you see the CT here, the upper pole, very nice stone is there. After that, one stone is back to back is there for the upper pole, and one stone is there in the lower pole. One stone is there in the middle pole. So definitely total 1, 2, 3, 3 stones are there on the behind the main stone and below the main stone. So there is no harm once going inside and seeing the calyces. So if I insert access sheath post-tented, I use a disposable scope. I will go inside without injecting contrast. I will see all these stones. After that, I will inject contrast and take them out. If the basket is not there, I will finish the stone small there in there itself. Now, Aditya Sharma has shown the recording of the position because we have draped. That play will be there. After that, he will speak.
Chandramohan, one question. Why you want to do RIRS first and not the PCNL
Sir,
first?
if you do PCNL, the amount of the bleeding which is there will spoil RIRS. RIRS is a tubular vision. It is only 3 mm tip scope, whereas PCNL scopes are, as you know, around 6 mm to 8 mm. Vision will be totally disturbed if you do later. And one more thing, small stones to be tackled first because they are difficult to remove in RIRS. These are the 2 reasons we are doing RIRS first.
I'm just handing over the mic to Dr. Adit. He will explain his plan of action.
Yeah. Good morning, everybody. Am I audible?
Yeah, we can hear you.
So, as Dr. Chandramohan sir explained, that first we want to tackle these 2 small stones. We will try to get them into the pelvis, or if it is not possible to drag them, maybe he'll try to break it. At the same time, he can push the contrast. So actually, things can go simultaneously also. He enters and pushes the contrast, and through that under fluoro, I can take the puncture on the superior calyx. The position video we have played. So now we will be playing the video how we have positioned the patient, because we have already draped now, so it's difficult to understand. The one concern regarding supine is there, that whether we can approach the upper calyx or supracalyceal puncture easily in this or not. So that is one thing we'll try to see that it should happen. लाइट थोड़ा सा कम.
Aditya,
Yes, sir.
will you do puncture under a guidance of RIRS with the CRM or totally separate?
So we are under fluoro only. Although endovision puncture is possible, but it may be difficult to make the scope reach there from below, because the stone looks impact upper calyceal infundibulum.
You may not do it, but can you just demonstrate how people are doing, or you can do it so that the audience can see it? Because these are the cases which we don't come across regularly.
Plan is the piece puncture, but after the guide wire comes into the kidney, I will go and show where it is coming from.
तो डाल दो इसको, पूरा डालो वो ठीक. ये इसको डालो, हाँ बस ठीक.
if you put in ECIRS position, the left side ureteric orifice looks high. So it will be little awkward till you insert the access sheath. Once you insert the access sheath, all the problems will go. Now I am inserting the access sheath.
Which size you are planning to put?
Sir, I am trying to use the Biorad endovasive scope, which is 7.5 tip and 8.5 shaft, which goes through the 10 by 12. I am using 38 centimeter Rocamed 10 by 12 access sheath, which is universal, can admit all the scopes, except old digital scopes. Now I am
Yes, yes.
Can you hear me, sir? Hello? Can you
पीछे लो,
hear me,
पीछे
sir?
लो,
Garang, sir?
पीछे
Yeah, yeah, we can hear you.
हाँ देखो.
Sir, there is a small video of the positioning.
Huh.
So he'll be playing the video now.
Okay. So before he starts, now you just show it. The sound is. We can't hear.
Yeah, this is the.
I have not injected. I have not injected contrast. Kuch there.
ये निकाला.
Sir, are you seeing the endo view?
No, we cannot see.
Endo view, please.
This view has to be.
Endo view.
You stop video now. Yeah, we can.
Endo view, are you seeing, sir?
Yes, we can see it.
I am showing the upper calyx.
Huh, okay.
This is the upper calyx. This is a large stone.
Yeah.
This Aditya will puncture because I don't want to do. We can do, but it will take time. This is one stone just below that, very small. It will take very less time. Respiration control, please. And this is the middle calyxal stone, which we thought. And now inferior calyx, we are going. This is the inferior calyxal stone. This is reasonably big stone. These two, we can,
Keep the mic near to.
that mic थोड़ी देर तक
इसको निकाल के सर.
ठीक आ जाओ. Why are you standing there? You come here. Hello.
Yeah.
Sir, can you see one stone in the middle calyx?
Yes, we can
I
see.
don't want to inject contrast. I will directly, instead of wasting time, all these calyxes nothing, but inferior calyx can you see here? Siam, one show के कितना bend हुआ? देखो sir, that is inferior calyxal stone. Siam दिखा दो. कोई Siam दिखा रहा है?
हाँ दिखा रहे दिखा.
Yeah.
ये हमारा.
Siam, like this. Sir, Siam,
Can you adjust your mic? I think you are not wearing mic.
Take this one, please. Please take this.
Just 1 minute, sir.
I don't have basket, sir. So I will do in situ because this is flexible. Water band karo thoda. Whenever you are inserting the laser fiber, better to decrease the water flow. Otherwise, water will push the laser fiber and you will be passing, laser fiber will not come. Now laser fiber has come like this. This respiration बहुत ज़्यादा है madam. Respiration.
Chandramohan, can you just repeat again what you are saying? Why
Sir-
you want to stop water?
Laser fiber जब pass करते, it is so smooth. When you are using the water, it won't move. It appears as if you are moving, but it won't come out. Now, give me the laser settings. 110 I am using the laser settings, sir. This is one stone which I will do later on. First I will do, see the flexion is happening here and laser fiber is seen. This means then it is this position. This is like a matrix. How to do matrix is just to use fragmentation mode only. Ready. See, now I am doing this inferior. Can you show the C arm there? No contrast injected because they are radio opaque. See, I am just playing. No skill here. Just keep in the center, respiration stop, and keep moving. This is all the mug which comes into the pelvis can be cleaned by Aditya sir. Time we should not waste. Ultimately, ECIRS we are doing. See, this somebody has to hold this. Respiration control, please. See, every time laser fiber you have to readjust like this. Very. If you make pieces and get into the pelvis, it is better. He will take it out because he can come into the pelvis. So there is no need to powder. Respiration come, please, thoda. Yeah. I want to make pieces. 1.5 kar do. Because the see, they have become two pieces. If they come out, I am happy. I am using gravity irrigation here.
Any reason behind gravity irrigation?
Pardon, sir?
What is the purpose of gravity irrigation?
हाँ सर, ये 50 ml सिरंज नहीं था तभी ग्रेविटी इरिगेशन यूज कर रहे हैं सर. Otherwise, I use 50 ml syringe. Gravity irrigation, lot of people are using. See, this is the advantage of the thulium fiber laser. It will break if even you are in awkward position and let them come out is the, I am little awkward position because my 180 degrees screen is kept on the other side. So, if the, see, I want to deliver them out into the pelvis, that's all. We can flush with 50 ml syringe, hai sister? Karo, nikal ke 50 ml syringe se flush karo. See, they are coming out. Otherwise, this calyx might have required. See, ek बाहर आ गया, बाहर आ गई. This after PCNL, if you do, blood will be there, sir.
Yeah.
So that itna, already I am suffering with for vision. 50 ml syringe se flush karo. Flush karo. Infundibulum is little narrow, so let them come out. Now if water is not there, see, vision will be like this. Better not to activate. 50 ml flush and gently. Flush. Turned. Air bubbles inject कर रहा है, so no problem. See, laser fiber पीछे चले गया था, so you should have that consciousness in your mind. These two fragments, if flush karo, yes. See how the 50 ml is flushed.
Yeah.
My job is done. So appropriate flush like this, over.
Wow.
So now later on, the impacted stone, this is the other one. This. इसको भी मैं उधर से actually basket है तो better.
Can you show us in Siam?
Siam, please. Siam, that stone has come into
Yeah.
See, now I am finishing this. इसका ये calyx जाना, it's very difficult from the upper calyx, especially in supine PCNL. Prone PCNL we don't know, but see, this is a large stone.
Large
My
stone,
job
yeah.
is to make fragments, that's all, not powder. हाँ बास्केट है तो रखो रखो, ये impacted है, बास्केट से नहीं आएगा.
So this is a large stone actually. You
This
know,
is the
it
large
was
stone. I just wanted to finish and give it to him so that he will take out these pieces through his tract. In the pelvis. My aim is to keep them in the pelvis, not to make powder. Huh? Fragmentation. Fragmentation with high energy. Thoda. Yeah. Now I will give to him in another. So this 10 minutes of time will avoid the laser fiber sometimes go beyond. Can you appreciate the
Yes.
digging effect, sir? ये पकड़ना यार थोड़ा, मैं बोला आपको ये पकड़ना access sheath. Access sheath पीछे. Access sheath 1%, water please. And it is also impacted stone, little difficult लग रहा है. थोड़ा 1 or 2 fragments बनने के बाद the laser is not actively hard stone, but effectively नहीं हो रहा है. एक fragment हो गया तो जगह मिल जाता है. And the type of the infundibulum, even your this thing also impacted. So just give me 2 minutes time. Water flush please. लेजर फाइबर देखो, ये ज़्यादा अच्छा काम नहीं कर रहा. बढ़ा दो एनर्जी 1.5. We want to stand by. वाटर प्लीज. इसको पकड़ना है आदित्य, थोड़ा हेल्प करना है, ये तो करना थोड़ा प्लीज, बिकॉज एनीवे यू विल नॉट बी एबल टू डू. हाँ राइट. Did you observe, sir, the lasing effect is not happening very well? Because there is no space, it is impacted.
yeah.
Unless some space is there, laser will not function, because water surface is essential. See,
So now it's
will
working
work.
well.
Water bubble is essential for laser to function. Water please. Water जब नहीं रहता है, it will not break. It is breaking now,
Yeah.
like that. So impacted stone में this is the yeah, all of them are coming out. Whenever he requires, I can give later on them. Last piece, ये piece कर दिया तो then see, now I pushed to have little space.
Can you just explain us how you are doing the movement of your hands
Yes,
to
sir.
manipulate? After you finish, just tell us.
Yes, sir. No problem, sir. See, मैं blindly fragment कर रहा हूँ, sir. I am not able to reach in the deep impacted region. You are understanding, sir?
Yes.
If they just come out, I am happy. Because वो pelvis में तो he will anyway come into the pelvis, no, sir. Water, please. Every time he exchanges the, see, everything has come out.
Yeah.
That's all. So this 15-minute job is done. Now my job is over. Now I will inject contrast like a ureteric catheter. My flexible scope acts as a ureteric catheter, so that he can puncture. Every calyx I will show him, whichever want he want. Give me the mic give to Aditya Sharma, sir. Give me the contrast to me.
Chandramohan,
Sir.
in this, you made a small puncture into the calyx.
Yes, sir.
Will it make any difference?
No, sir. That is only 1 mm, sir. 1 mm, 2 mm. 1 mm. अभी आप contrast inject करने के time में देख लीजिए, sir. Intravasation होता है नहीं होता है पता लग
Yeah.
जाता है.
See, these points are very important for
Yes,
those
sir.
who are beginning.
Yeah.
Because,
Inject
you know,
contrast.
people get afraid because
Yeah.
of that. But because of your surety and your experience,
Yes, sir.
it will make a
Now
difference.
focus on Siam only. See, sir, this calyx might have not reached with upper calyceal puncture. You agree, sir?
Yes.
So all I have cleared. After that, he will come with scope into pelvis. He will wash out them. Is it okay, sir?
Yeah, fine.
Yeah. So now I will hand over the mic to Aditya Sharma. And stone, अगर उसको पता नहीं लग रहा है, if he feels that the contrast is filling the stone, I will go to him to the stone and show the stone. Aditya, if you want. Yeah, just एक बार कहाँ है बोल के. Water flush please, निकाल दो. निकाल दो. ये सब Aditya, just hold this. See, this is the stone which he has to puncture, sir.
Yeah.
Now, Siam, please. Siam, see, that is the infundibulum, sir, which is
Correct.
protruding stone. Entire upper calyx is filled with stone. So he will puncture the upper calyx in supine PCNL. Then he will come to the bifid, partially bifid system into the pelvis. And all these stones, if they are not accessible, I will give it to him. That's all. Thank you, sir.
Can you just explain us how normally you do endoscopic puncture?
एंडोस्कोपिक पंक्चर वो पंक्चर होने के बाद मैं दिखा दूंगा सर. लेट हिम पंक्चर सियाम गाइडेड.
Okay.
आफ्टर दैट गाइड वायर कहां से आ रहा है आई विल कंफर्म, सो दैट इफ द गाइड वायर इज कमिंग फ्रॉम द इन्फंडिबुलम आई विल से इट इज नॉट करेक्ट. माइक माइक सर को दे दो. आई होप I hope you got the point, na sir.
Yeah.
He will puncture the upper calyx and he will get the guide wire into ureter. I will go and see where the guide wire is coming from. If it is coming from deep from the cavity, it is good. And we can watch the entire dilatation while he is doing the dilatation. So that dilator will not go anywhere.
Is it possible to guide him with your light of?
No sir. Kidney to itna light to transmission to nahi hoga.
Light will not come
Light
through
will
the
not come,
skin.
sir.
Actually, for endovision, if they had the stone been only in the pelvis, then one can cross the stone and the tip of the scope can be kept where the desired calyx is there. And one can target the tip of the scope and obviously with little bit contrast. So that's how endovision puncture is done.
For Aditya Sharma to puncture, this is like ureteric catheter, sir. Kahan dikha raha hai? This is the ureteric catheter. It acts like for flushing everything. My
Okay.
access sheath acts as a ureteric catheter. My flexible scope acts as the visual ureteric catheter. Wherever
Okay.
I want to flush single calyx, I can go and inject contrast. People are appreciating this micro ECIRS.
So now my puncture planning is like this because we are going through the superior calyx. So I have taken puncture more medially and posteriorly. And here is the posterior axillary line. This is the tip of the 12th rib. So we generally mark the patient properly. Even if the marking gets wiped out, one should feel for the tip of the 12th rib and try to remain behind it. But in superior calyceal puncture, that's not much of a concern because our puncture is anyways much behind the posterior axillary line. So there is this much space is there. So that's, and the puncture also move upward. Had it been an inferior calyceal puncture, the puncture site would have been somewhere here. So I'm going between 12th and 11th rib, and I'm trying to target the calyx in which the stone is there. Yeah, it's a contrast.
See, now I am injecting contrast from the access sheath closed. Obturator. This is the obturator of the, I have closed the obturator. Now slowly I will inject. See, I am injecting the contrast. See the contrast. Whenever I want, I will inject this. Contrast. Now entire upper calyx is visualized. See, Bas.
So now how we enter the system, see, one has to see which is the lateral most calyx towards you, because our puncture is happening from the lateral side, not like bullseye where the needle is superimposed over the calyx. So in this case, you can appreciate the movement of the kidney. I have gone perpendicular to the surface of the skin, and now I will try to target my puncture. If my needle is too medial or too anterior, you can see you can feel you can appreciate the movement of the kidney with the needle tip.
Yeah, we can appreciate.
So with this, so now I am
He has
inside.
punctured.
I really don't have to confirm it, but the other way of confirming it, one can rotate the C-arm craniocaudally. You can show this C-arm. Rotate,
Head taraf.
rotate like this.
Head taraf. नहीं. Head taraf rotate. Head taraf. कल किया था ना? ऐसा नहीं.
No.
उस तरफ. Head taraf. ऐसा
ऐसा. So if had the needle been too anterior or too posterior, there would have been relative movement between the calyx and the needle. So there is a short mnemonic ASPO, ASPO. So anterior same, posterior opposite. The X-ray source is below the table. So needle goes in the same direction as the X-ray source, it is anterior. If the needle goes opposite to the X-ray source movement, it is posterior. Now you can make it zero
make
again.
it 0 वापस.
You can see there is not much relative movement in terms of calyx and the needle. So I am inside, and let's see if the water comes. Yes.
Water is coming.
So little turbid urine is coming, but I guess maybe some stone dust also. Yeah. So now I am passing the guide wire. Puncture is quite in line. So stone is so we have gone in the
Now
ureter.
I will check where it is coming from. I will show that puncture. Give that quickly. Right card on.
So this is a dilated calyx. If had it been a not so dilated system, the endovision puncture really helps because sometimes one may enter the calyx not end on, rather from the side or maybe through the
That I
infundibulum.
will confirm.
So that can be confirmed by the endovision.
Endovision. Now I am passing. It is only same person can come also, sir, below.
You can
If
connect
you don't
the,
have two systems, water please.
connect the
See,
nephroscope
can you see the
camera,
endovision?
nephroscope and
Little
everything.
bit of red. See the guide
Dilated.
wire where it has come from. Can you see the sir guide wire?
Yes, we can
You see,
appreciate. Yeah.
Now everything I can see the dilatation also.
This one.
See, it has come from deep root. That means
Take
no
knife-
chance of injury,
knife,
any vessel around this thing. That's all.
Yeah.
This is
it
what
will
we
go.
wanted. After coming here, all these pieces he will suck out. If he cannot suck out, I will give it to him. Is it okay, sir? The dilatation now. You dilate and I will show the dilatation.
Yes.
Also. And we can take out the guide wire also outside and hold it so that his dilatation will be very good like SPC tract.
Yeah.
So in dilatation also one has to see, because we are coming from the lateral side. So there is again possibility while pushing the dilator, I can go either anterior or posterior to the kidney. If I am going above or below the kidney, there will be buckling of the guide wire that one needs to appreciate. If there is buckling, then the direction needs to be corrected.
No, but as the Chandramohan said, if he brings out the guide wire outside,
Bus.
then even without CM you can dilate it.
Yes, sir. We are doing now like that. CM-less PCNL. Come, Aditya. Come. C has come. What else you want? Why you want?
CM, correct.
CM? You tell me. I'm not exaggerating. It is possible.
No, no, it's really beautifully seen over
sir,
here,
without
and we can
CM,
understand.
nicely seen. Everything can be seen and everything can be done without CM. If you have ultrasound for puncture,
Give a large,
there will
large
not be any
size
role
sheet.
of CM.
This one. You can put the sheath on that and it will pass on that. No? Take through that only. What size? What? The large stones, I'm
Yeah.
thinking it is 21,
Yeah, yeah.
22. Yeah,
Yeah, yeah.
Karl Stoll's teeth. So I'm just
Sir,
planning
he
to
is passing
make bigger
22.
punctures, bigger fragments, and just take them out.
This is metal rod
This is the dilator with this
with
sheath.
the sheath.
Yeah, this is
Which company?
the stores. So in stores they also have a longer access sheath for supine.
Water, please, here.
You can see there is more movement of the kidney.
You
In,
see, he is moving kidney towards my scope. Pushing, see.
so like yesterday, Gaurang Shah sir showed that little screwing movement. You can proceed and you can enter the system.
How it has come. Can you see the end of view, sir?
Here
Yes.
it is.
See, steel rod has come.
Yeah,
nicely.
with this movement, there is hardly any bleeding.
Yes,
Yeah.
one drop of bleeding is not there in the endovision, sir.
Yes, we can see it.
Yeah. So that means very safe puncture and safe dilatation.
So endovision also helps that one may not overshoot the dilatation. Sometimes
Yeah,
there
we
is
stop there.
perforation. So,
Medial overshooting can be avoided with this.
and sometimes we underdilate. So all those things can be seen directly that my dilator has reached there. Now it is inside.
I'm
Nephroscope
not
lagao.
seeing it. It will
Nephroscope
just come a
lagao.
little more
Yeah,
inside.
waist stone is.
Yeah. So he doesn't want to come by the side of the impacted stone. He stayed back behind the stone.
Chandrabhavan, we are really impressed, na?
No, sorry.
It's really looking beautiful, all the three things.
I'm happy that if somebody can.
You know, we have got your Siam vision, we have got endoscopic, we have got surface.
Yes, sir.
Fluoro is
Camera. ये कैमरा कहाँ
The
है?
guide wire also I can keep in
इसमें
position.
दोनों
sir.
इनपुट देके आप PIP कर
I
सकते
can
हो.
pull the guide wire and keep
Both
in bladder
inputs
so
can
that
be
it
given
won't slip out.
and you can make PIP in that. In ECIRS, there is one option in all medical grade monitors. There is option of picture in picture. So one can connect the flexible scope view and also the other camera because we are using chip on tip flexible URS, and the other camera view also can be taken on the same monitor. Oh, which one? This is not connected actually. This they are giving this. They are connecting it. Switch on the system. They are switching on the other system. There was some issue. ये इसको इस पे लेना इसका मॉनिटर एक दूसरा मॉनिटर तो है ना उसमें आ ही रहा है you take input into this. I'll connect this only. पानी 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 ये होल्ड connect the water हाँ water.
Sir, I am disconnecting the my view, and
Yeah.
he is doing because it's not required now.
okay.
After he finishes, then both of us will come in the end of view. That time Siam view is not required.
So
Fine.
in this stores nephroscope, the water connection is rotatable. So many times what happens if it is coming from below or above, sometimes it hits the table. So you can rotate it comfortably, like any direction.
Yeah, that is adjustable.
Yeah, white balance. थोड़ा brightness कम करिए, light कम करिए. Reduce the brightness.
You can go on a small scope and can do the adjustment.
I'm doing it, but it is showing too bright. Light has to be reduced. This light also you are saying. ये Hmm. Now I'm doing the white balance, so this is perfect now. So sister, just hold the nephroscope. I'll withdraw my dilator.
Flush, I can flush the system with the flexible scope for him, sir. It is a big channel, 3.6 channel, so that water will be nicely going
I
and he
need
will evacuate.
a stool to sit here. एक chair या stool दे दो. So the other advantage of supine or maybe necessity because you have to your hands are pretty down, so your arms and shoulders are relaxed. So one doesn't have to work like this. I can comfortably work like this, and I can even sit and operate comfortably. My C arm stays in the same. It's going down जा रहा है, नीचे जा रहा है, उसे fix करो. So my C arm stays in the same position. I don't have to move back and forth movement of C arm, and also the hands and overall body of the surgeon is much away from the C arm because we are approaching the puncture from more laterals. At least a foot or 1.5 feet difference is there. So now I am entering the system. ना ना कुछ नहीं पकड़ना है ये स्टूल दूसरा ले आओ ये so we are here anyways स्टूल दूसरा दे दो
No.
I will need laser. So now I'll start breaking the stone. Yeah. Acha, okay. They're connecting the endo view. I'm looking at the stone. We are inside the system, and the puncture is perfectly in the center of the calyx. Hmm. Where's the pedal? Laser pedal? इधर इधर ही दे दो. थोड़ा सा दूर रखो दिखे. पानी गिरेगा. Endo view is coming. Okay, okay. So I think everybody can see
Yeah.
we are at the stone. Now I am taking the laser. I'll start breaking the stone. ये dusting है. ठीक. So I'm using fragmentation mode because stone is hard. The same 1.5 energy and frequency is 10. How much? So let's see how it behaves here. So ready. We are using here thulium fiber laser. Ready? You can increase the.
Am I audible there?
Yeah, we can hear you.
Sir, Adit has done a wonderful job. He's now breaking the stones. I am just switching over to the other side. Dr. Harshvardhan is ready with his RIRS.
Okay.
I am also helping from below flushing the water as ureteric catheter with my flexible scope. That's a luxury if two surgeons are there and two monitors are there.
And it is a privilege to operate with Chandramohan sir and once in lifetime opportunity.
I think very few workshops we are able to see ECIRS.
Yeah, thanks to Kamlesh for keeping this case.
Welcome,
So
sir.
all the stone dust is coming from the side of the nephroscope. I don't have to use forceps. Everything is getting flushed by the gravity drainage.
Okay, Kamlesh, you are ready for the second OT?
तो एनर्जी और बढ़ा सकते हैं. कितना रहता है मैक्सिमम? हार्ड स्टोन है ना.
Yeah. Hello,
Hello.
am I audible, sir?
Yeah, you are audible.
Okay.
Go ahead.
So, good morning, all the respected seniors. First, I would like to congratulate Dr. Kamlesh Maurya, sir, and all the West Zone team for organizing such a wonderful Stone Conclave conference in the Bilaspur. It was an academic feast for all of us. So, today I will be doing an RIRS on the right side. So, on the plain X-ray, I would like to show some. This is an interesting case for RIRS also. Before going to the case, one has to study the importance of looking at the imaging. In this case is very much, as on the right side you could see there is a stone, a round shaped stone is there, but also with the stone we can see some kind of calcification on the plain X-ray. Similarly, on the left side there is calcification in the renal parenchymal region. But on the right side, as we are planning the right side surgery first, the coil of the DJ stent is in the pelvis. So the stone doesn't seem in the pelvis and it's a round shaped stone. So in such scenarios, there might be a very rare possibility of a diverticular stone. One has to anticipate this thing and then go with the scopy. On the plain CT scan, you could see many calcifications in both the parenchymal regions of the kidney, and there is a small round shaped density seen in the right kidney, which is not very well appreciated. So again, the possibility of a diverticular stone rises in such scenarios where there is a nephrocalcinosis. So can you appreciate the CT findings?
Yeah, but can you just focus on that properly so that we can see?
Yeah, yeah, sir. So kindly focus on the CM image, on the plain film. So this is the calcification seen
Yeah.
on both the sides.
You are going to tackle that?
So no, no, no. There are parenchymal calcifications clearly seen on the CT. So no need to tackle those calcifications. We'll be tackling the main stone. So on the right side first.
But the left side is obstructive, no? So you don't want to do the left side
So actually
first?
the consent of first right side surgery has been taken from
Okay,
the
okay.
patient, and anyways there is a stent on the left side also. So for this surgery, sir, I'm using the Bioroid scope. Uh, we have already we have inserted the excess sheath, which is of Biorad company only. It's a 10 by 12 excess sheath. Nice outflow of the urine is coming from the right side kidney. We'll be using a TFL IPG laser for this case. So this scope is a very light scope, and now they have come up with an unlimited usage. There is no time bond to this scope. Earlier it is to be 30 hours, but now they have removed the timing. The working channel of this scope is 3.3 French. So we'll be going inside. Endo view, please. The first part in doing RIRS is to properly inspect the system. So we have kept our excess sheath in the proximal ureteric region, just distal to the PUJ, so that there will be a good outflow. Keeping the vision in the center, we have gently inserted the scope into the pelvic ileal system. So first thing I would like to do is inspect systematically the whole system, so that a clear map is ready in our mind to tackle all the possibilities. So this is the renal pelvis. So I'd like to inspect the renal pelvis first. I will be going in the superior calyceal region. So this is the superior calyx. Oh, so in the first go only we have seen the stone. It's a nice stone sitting in the superior calyx region.
Can you show us on Siam where we are?
Yeah, yeah,
which-
definitely, sir. So see, exactly on the Siam, in front of the stone, my scope is there, sir.
No, we can't see Siam. Can you just
Yeah.
surface?
So it's in the surface view, please. Are you able to see now?
Yeah, now. Yeah,
Please zoom in. Zoom in.
yes,
Yes,
now
sir.
we can see it.
So now I will just withdraw my scope, go back in the middle calyceal region. So you can see some parenchymal calcifications here. Fine dots are seen.
Hmm.
This was the thing what we were looking, I guess, in the Siam, on the plain film and the CT, plain CT.
You know, if you show us the Siam,
Siam, yes, sir,
view,
yes,
no,
sir.
then
Shooting, sir.
we can really compare it.
This is the region of the lower pole. Shoot. Please, sir.
Yeah.
This is the
Okay.
calcification.
Hmm.
So this is the middle pole.
What calcium?
Shoot.
Yes.
So
So this calcification, this stone you can remove?
Yes, yes.
This you can remove.
Yes, sir. This we can remove gently. We have to lace this thing,
Yeah.
make it big, and let's see, sir. First, I would like to deal with the bigger stone. We'll start lacing the bigger stone first, sir. Tidal volume थोड़ा कम कर दो. Quite heavily breathing. Okay. Give me the laser fiber. So it's a gravity irrigation I'm using. Yogesh. Laser. What's up? Okay, okay. Fine, sir. सिस्टर आपका हाथ लग गया किसी का. तक ना तो हाथ. तक. तक ना तक मला हाताला धरायला लागेल. Rahul, this is a 150 micron. Okay. So we'll be using a 150 micron fiber, sir. Just hold on. That nahi hai. Okay, we'll straighten the scope. Bas. Lock it. अंतर अंतर आगे बोलो. So whenever there is a bend in the scope, the fiber won't go. So we have to straighten our scope, get the scope back into the pelvis first, insert the laser fiber, then only maneuver the scope to the desired calyx. Otherwise, the laser fiber might perforate the scope. So we are using an energy of 0.15 joules at and 160 hertz. So it's a totally 25 watt power what we'll be using. Yeah, ready. हे कर मागे घे थोडं फायबरला स्टेबलाइज कर. हातात राहू दे थोडं पुढे जा. बस. I will be painting the stone. These sparks are very common with the thulium fiber laser, but no need to worry as they won't cause any damage to the scope. Irrigation. It's a hard stone.
Compared to holmium, you think thulium is much better?
Sir, compared to holmium, thulium is much faster, sir. Regarding the dust, with the frequency and popcorning effect of the thulium fiber, the dust size is very much fine while doing it with thulium fiber.
Now, given the choice, which energy will like to use?
Sir, thulium fiber, definitely. Versatile, sir. The only thing are these sparks, but recently I have read one post on Twitter from Oliver Traxler, sir. They say when the disulfide bonds of the stone they break, when there is disulfide bond breakage is there, it will create sparking. So no need to worry about the spark while operating with thulium fiber laser. So the main reason behind the sparking is the breaking of the disulfide bonds.
Yeah, but this spark, whether it will damage your scope, number one, or the mucosa.
हातातच राहू दे fiber. एक आता. No, sir. There is no damage to the mucosa or the scope. As I have been using thulium fiber laser since last 2 years. Done many cases. It is only at times when the stone composition is quite different, then only it sparks around. So we have to remove the fiber now. As you can see that the fiber, we have to cut the fiber and again insert it. Yeah, because the sheath has come out. Just chip it. Just chip the fiber and give it back. Yes. Are you able to appreciate there are some black spots and the rest of the stone is white?
So what is the conclusion
Yes,
of
sir.
that back where
Yeah,
there's a black spot?
that is the part where the disulfide bonds are getting the laser is damaging the disulfide bonds where the spark is created, and then it is giving the charred effect. Charring is there on the stone surface. I will like to come back as we are again reinserting the laser fiber. So I will come back into the renal pelvis. You can see the dust is already started coming out from the calyx. Fine golden dust is there. We will straighten our scope and then only insert the fiber. Otherwise, it is going to perforate your scope. We'll fix the laser here. Dr. Yogesh is assisting me, Yogesh Kaze from Pune. Yes. Karnataka. So once the laser fiber is fixed, we'll go back. Irrigate. So there is a turn here. So we have to negotiate the turn every time. We'll just, that's it. Okay. Ready?
पार्ट वहाँ से हाँ यही है
Can you repeat your laser setting?
पानी पानी स्टैंड बाय कर लो
Can you repeat your laser setting? Aditya?
the laser setting is
Uh,
2 and 10.
No.
So it's a very hard stone, so we utilize high energy. Push the water. Yeah.
Harshvardhan?
So you can appreciate all these stone fragments are just coming by gravity. I have not used the forceps even once. And here we have cleared completely. This is the pelvis. This is the flexible URS. You can appreciate here.
Harshvardhan, are you with us?
So now in the Siam, you can see some dust has gone
Hello?
into the middle and inferior calyces. Siam view is there.
Hello,
So we'll retrieve
Hello?
those stones.
Hello? sir. Are you able to see the nephroscope view of the flexible scope, sir?
Yes, we can see
Now
it.
he will go inside. I will withdraw, otherwise I may damage my scope. I am withdrawing. Let him come and clear. Usually they might have come already out. If you see Siam there, no radio opaque shadow sheen. This all he can suck out or take the forceps and suck out. At the end, I will inspect all the calyces and inject RGP and see whether I am missing anything. Siam picture, where he has come from the upper pole to my flex. So our picture.
So
Yeah, so we have seen all the three views. Thank you very much. Can we shift to Harshvardhan's case? Harshvardhan, can you hear us?
Yes, sir. Yes, sir.
So we just want to, can you repeat your settings?
Yes, sir. It was earlier, it was 0.15 joules and the frequency was 160 hertz. Now I have made it 0.20 joules and the frequency of, I guess, 75 hertz. As it is a hard stone, I have to increase
Harsh.
the energy, sir.
Harsh,
Yes, sir.
this is Kandarp here.
Yes, sir.
Nice job. But can you now change your settings to 0.5 or 0.7
Yes, sir.
and frequency of 15?
Yes,
I
sir.
just want to see the sparking effect.
Yes, sir. Fine. We increasing it to 0.50
0.5 or 0.7, whatever you feel.
and the
Because the stone is hard.
frequency of 50 hertz.
15, 5, 1, 5.
1.5. Okay, fine.
Okay.
Okay, sir. Total it is 8 watts now. 0.50 and 16 hertz. We'll be starting stuff. Irrigation.
Now slightly keep the fiber away from the stone. Just show the face of the laser fiber to the stone. I just want to see the sparking effect. Are you getting the same sparks as you were getting with the higher frequency? That is what is the point.
Yes, sir. So
Now-
the sparking effect is more on the center of the stone.
No, you put it in the center of the stone.
Sir,
No
yes, sir.
problem.
Still we are
But
getting the spark
just,
effect.
yeah, that is what we wanted to see.
Yes,
you
sir.
know,
The
that-
spark is still there.
Okay.
Are you able to appreciate the spark, sir?
Yeah, we are seeing the sparks.
See, the sparking is inevitable in thulium fiber.
No, sir.
Sir, but
Because
this
yesterday,
sparking doesn't
I
happen
think
with
when I
every
was
stone.
operating, you must have seen the stone was very hard. And this is a study I'm doing. That is the reason I'm asking. I just wanted to make sure that whether the stone, besides the stone composition, whether the frequency has any role into it. Because I think Ashish, you were moderating. While I was operating, there were hardly any sparks you were getting, except for the very center point where he's telling us. So are we getting, is the frequency has got some role to play into it? That is what is the point.
Sir, but this sparking doesn't happen with every kind of stone. Only in some selected stones only we are able to see the spark.
No, sparking is found, like, initially when I was doing RIRS, I was using a setting of 0.1 and 100 frequency. So total 10 energy. So that time also I was getting the sparks. But when I changed to the setting like 0.7 or 1 and 10 frequency or 15 frequency, what I have noticed is that the sparking is comparatively less. But I wanted to make sure that with experience of many of us, those who are doing RIRS on a regular basis, are we having the same kind of impression? That is a point. That is the reason I told you to decrease the setting. Now you can go back to the settings you are comfortable with. No problem.
As you have taught us, all of us juniors, that we have to reduce the volume of the stone first. Don't target the center of the stone, come from the periphery and then at the end, deal with the center. Am I right, sir? Kandab, sir?
Yeah, you're right.
Yes, sir. Care has to be taken not to damage the mucosa.
Although in thulium you have the potential of increasing frequency very high, but actually high frequency is practically of no
Come na, पानी
utility
इसमें जाते हैं.
because
उसको
you will
prick
get
करो
the
ना पानी
vision
को,
which is
पानी
really, which
flow
will
नहीं आ
become
रहा है
very
boss.
poor because
Prick
there will
कीजिए
be all
please.
slow storming
Pathfinder
effect.
में ही नहीं पानी आ रहा है.
And therefore beyond 100 and 150, even if there is a provision, it is of no utility from the practical standpoint because moment you put that much frequency,
पानी नहीं आ रहा है, पानी नहीं आ रहा है.
the stone, the jumping and slow storm effect is so much that every 2 seconds you have to stop for some time and then allow that
Alaga.
dust to settle. Again you do it. So basically 100 is the frequency or at the most 150 is the one which practically can be utilized.
Absolutely correct, sir. And with this thulium fiber laser, like if you look at the machine, we have a potential to increase the frequency up to 2000.
So that is never
But
required.
it is never required.
It is never required.
Secondly, with the higher frequency, the fiber wobbles too much, so sandstone effect is more.
So it
The vision is
it
distorted, and
that
you are likely to
provision
cause
has no
injury.
meaning. That provision has no meaning.
So I think there is a company now. I
Pani
think
on karo.
probably Lisa Laser have come out with a Lisa company has come out with a thulium fiber laser, which probably has a capacity to increase the frequency up to 200 or 250 only. It doesn't go beyond it because it is not necessary. Nobody is using in a
Never
practical life.
necessary. Yeah.
चलो. Air चल रही है.
Only thing is, Harshavardhan, when you decrease the frequency, comparatively your speed of surgery goes down. So, and because frequency is now basically used for the speed of the
Yes.
procedure.
Yes,
But
sir.
So if you increase the power, increase the joules, then the size of the fragment which is going to be formed is going
they're
to become
slightly
bigger
bigger,
and bigger.
slightly
Yes,
bigger,
yes, yes,
correct?
yes.
So if you decrease the joules, then your size of the fragments which are formed will be smaller and smaller. And therefore, actually, we start with 0.1 and 100. And then if the stone is slightly bigger, harder, then we go to 0.2 and 100. And most of the times it forms a fine dust with 0.2 and 100. Initially start with 0.1 if it is a dihydrate stone. 0.1 and 100 is more than enough. It will eventually powder everything.
Sir, with thulium fiber laser, while we do popcorning, where 0.1 joule
high
energy is there and 200 hertz frequency is there, 200, 250, 275. The temperatures inside the systems go very high. At times you can feel the outflow water being coming as a warm water or a hot water, which you can feel at the hand, which you have kept at the access sheath. So we have to be careful while doing RRS and popcorning, especially with thulium fiber laser, as temperatures might go very high.
So Harsh, for the popcorning, what is recommended is that you use a higher energy
High frequency
and
and high
high
energy.
frequency
Yeah.
with a longer pulse. So high energy means if you increase the frequency to supposing 1 joule, then in no way you can use a frequency of 100, because then the total power will be 100 watt. So what you have to do is that you have to decrease the frequency to 10, 20. Because with the thulium fiber, one has to be very careful that don't exceed your energy, total power more than 20 or 25. Otherwise, this effect which you are talking about, the temperature, the rise in the temperature and the damage to the tissue will be more apparent. In fact, I will share my personal experience. I did one 2 centimeter size stone with using when I was doing some kind of a study with the thulium fiber laser. We increased we use the entire energy, I mean 60 watt laser. So we use the entire energy, 60 watt, 300, and the setting was initially 1.5, something like that. Now, at the end of the procedure, I could produce excellent dusting, and I was very happy. Uh, Post-operatively, patient complained of the pain. Patient was discharged with the painkiller. After 7 days, patient came out with excruciating pain. So we thought that probably it is tent-related pain. So then still I got a CT scan done. The CT showed that there were a lot of stone dust which had come down into the ureter by the side of the stent. And then I went in and I took out all the sand as well as the stent. When I inspected the system, I was shocked to see that there was a completely whitish discoloration of the mucosa of the pelvic alyssal system, and as if I have produced some kind of a perforation kind of a thing. So one has to be extremely careful increasing the temperature, and so don't use your energy more than 20 by any chance. I have a limit of using it between 10 and 15 now, but 20 is the maximum permissible.
Through and through.
Yes, sir.
Hello, can you hear me, sir?
No, patient is doing okay.
Yes, we can hear you, Kamlesh.
Sir, we are just shifting to
But it was
OT1.
shocking. I mean,
Okay.
I have
They're
a
almost
recording of
finished
that
it.
thing.
We
I'll show
wanted
in one
to
of
show
the
you the end of
conferences.
Yeah, yeah.
It was
the
very, very
RIRS
good.
and PCNL.
I was shocked.
You can see the flexible scope from below is coming through the access sheath. Give mic to Chandramohan, sir.
Now we can see that. Kandap.
I could
Kandap.
go through the access sheath easily into the outside, and I am coming out. Both views we can see. He will come out. He will come in. Both views you can show here. I am going out and injecting contrast. All the small stones he has. See, I am in the. See, we both are uniting like this.
And there is one concern that with the supine, the system remains collapsed. But you can see I am using a rubber nipple here. I am blocking the outflow intermittently, and you can see nicely dilated system. I think the feed is not going, endoview feed.
We will inject the contrast and finish the case. Each calyx we will go, and Siam is enough now. Endovision is not required.
Yeah, we can see it, but we cannot see the endovision.
Thoda sa.
So Siam will inject contrast. Close karne.
We changed in TFL also. We used first 150,
Siam,
200
please.
micron, and then
Siam, please.
500, 550.
See how the
micron.
system, everything is. Then somebody take the picture of that.
Yeah.
Can you see the picture?
Im-
See the Siam view? Surface view Siam pe le-
Siam दिखा दो. Siam दिखा दो उधर.
Siam. Can you see, sir, Siam?
Yeah, we can see.
See, no stone seen. We have gone to all the calyces. No intravasation, no extravasation. We'll put a stent and we will not put nephrostomy. Is it okay?
Yeah. No nephrostomy. No nephrostomy.
Sir, thank you for the opportunity. I have to take the flight at 2 o'clock. I thank West Zone Urology, Chhattisgarh Urology and Kamlesh and all the organizing team and anesthesia team and hospital team for giving this opportunity to demonstrate. Thank you once again.
Thank you
I
for
also-
demonstrating good surgeries to us.
I also thank West Zone and Chhattisgarh Urology, especially Dr. Kamlesh Maurya for inviting me here, and we could demonstrate a very good case.
Yeah,
Thank you
nice
so much.
demonstration.
Thank you, everyone. इसको निकाल दो guide wire. Now we'll just put the stent and we are wrapping up the case. Zebra guide wire ले लो, मेरे को दे दो.
Yeah.
Zebra guide wire.
So we
Zebra
are going
guide wire है,
to
zebra है.
now just start lecture
Zebra
over
guide
here.
wire.
So we'll stop your videos. Okay.